Namaste Vidya, Hamisha Khush Raho Vidya. Today we are going to discuss with the disorders and tumors of the ovary. Myself Dr. ARTI, Department of Pathology, Associate Professor JAYOTI VIDYAPEETH. Now we will start with our topic that is there are many type of tumor in the ovary. This is very long and important topic. Just listen carefully. First is the follicular and luteal cyst. Normally, follicles and corpus luteum do not exceed a diameter of 2 cm. When their diameter is greater than 3 cm, they are termed as cysts. Follicular cysts are frequently multiple, filled with clear serous fluid, and may attain a diameter of 8 cm. When large, they produce clinical symptoms. Microscopic examination, they are lined by granulosa cells. Occasionally, however, they may be difficult in distinguishing between a large cyst of coelomic epithelium origin lined by flattened epithelial cell and a cyst of follicular origin. Such cases are appropriately designated as simple cysts. In luteal cysts are formed by rupture and sealing of corpus hemorrhagicum. The wall of these cysts is composed of yellowish luteal tissue. Microscopic examination, luteal cysts are commonly lined by luteinized granulosa cells. सेकेंड इज द पॉलीसिस्टिक ओवरियन डिजीज. आप सब जानते हैं स्टेन लिवेंथल syndrome. Stain Leventhal syndrome, it is a secondary name. PCOS is a syndrome characterized by oligomenorrhea, anovulation, infertility, hirsutism, and obesity in young women having bilaterally enlarged and cystic ovaries. The principal biochemical abnormalities in most patients are excess production of androgen and low level of pituitary follicle stimulating hormone, that is FSH. Current concept of pathogenesis of PCOS is the unbalanced release of FSH and LH by the pituitary. A hereditary basis for the syndrome has been suggested in some cases. In general examination, ovaries are usually involved bilaterally and are at least twice the size of normal. They are gray-white in color, studded with multiple small bluish cysts just beneath the cortex. The medullary stroma is abundant, solid, and free. In microscopic examination, the outer cortex is thick and fibrous. The subcortical cysts are lined by predominant luteinized theca cell and presents follicles in various stages of maturation, but there is no evidence of corpus luteum. Ovarian tumors are also there. The ovary is the third most common site of primary malignancy in the female genital tract, preceded only by endometrial and cervical cancer. Both benign and malignant tumors occur in the ovary. The etiopathogenesis is unlike the two other female genital cancers, cervix and endometrium. Not much is known about the etiology of ovarian tumors. However, a few risk factors have been identified as under nulliparity. There is higher incidence of ovarian cancer in unmarried women and married women with low and no parity. In hereditary, about 10% of cases of ovarian cancer occur in women with family history of ovarian and breast cancer. Women with hereditary breast ovarian cancer susceptibility have mutation in tumor suppressor BRCA gene. Interestingly, men in such families have an increased risk of prostate cancer also. Third, the complex genetic syndrome beside the above two main factors. General complex genetic syndrome are associated with ovarian tumor, that is the Lynch syndrome, Peutz-Jeghers syndrome, gonadal dysgenesis, and nevoid basal cell carcinoma. What are the clinical features and classifications of the ovarian tumor? In general, benign ovarian tumors are more common, particularly in young women between the age of 20 to 40 years, account for 80% of ovarian neoplasm. Malignant tumor may be primary or metastatic, ovary being a common site for receiving metastasis from various other cancers. A simplified classification proposed by WHO with minor modification has been widely adopted. According to this classification, ovarian tumor arise from normally occurring cellular component of the ovary. Five major groups have been described. The tumors of surface epithelium, common epithelial tumors, this is 60 to 70%. In serous tumor, serous cyst adenoma, borderline serous tumors, serous cyst adenocarcinoma is there. In mucinous tumors, mucinous cystadenoma, borderline mucinous tumor, mucinous cyst adenocarcinoma is there. In endometrioidal metroid tumors, There are some clear cell tumors and some are the Brenner's tumors. These are the nomenclature. Then germ cell tumors. Germ cell tumors again divided into 4 and 5 parts. That first is the teratoma, that is benign and malignant, and monodermal specialized teratomas there. In benign, there is a benign teratoma, benign cystic teratoma, and benign solid teratoma. Struma ovary is there in monodermal or specialized teratoma, and carcinoid tumors are also there. Then dysgerminoma is there. After the teratoma, the second is the dysgerminoma. Third is the endometrial sinus, endodermal sinus. Fourth is a choriocarcinoma, and some are other tumors are also persist like embryonal carcinoma, polyembryoma, and mixed germ cell tumors. Third type is the sex cord stromal tumors, in which the granuloma, theca cell tumor, granuloma cell tumor, thecoma, fibroma, Sertoli leading cell carcinoma, androblastoma, and gynecoendroblastoma. Miscellaneous tumor, lipid cell tumor, gonadoblastoma, Kuchenberg's tumors, which is very important, metastatic tumor. This is 5%, but it is very important, and others are also there. So, one by one, we will discuss in serous tumors. The serous tumor comprises the largest group constituting about 50% of all surface ovarian tumors and 40% of malignant ovarian tumor. About 60% of serous tumors are benign, 15% are borderline, and 25% are malignant. Serous tumors occur most commonly in second to fifth decade of life, the malignant form being more frequent in later life. Histogenesis of serous tumor is by metaplasia from the surface, coelomic epithelium, and mesothelial, which differentiates along tubal type of epithelium. In general appearance, there is a benign, borderline, or malignant serous tumors are large and spherical masses. Some masses, small masses are generally unilocular, while the large serous cysts are multiloculated, similar to mucinous variety, or may have one large loculus and may daughter loculi in its wall. These serous variants contain serous fluid rather than the viscid fluid of the mucinous tumors. Malignant serous tumors may have solid areas in the cystic mass. Exophytic as well as intracystic papillary projections may be present in all grades of serous tumor but are more frequent in malignant tumor termed papillary serous cystoadenocarcinomas. In microscopic examination, the features are serous cystoadenoma, which is characteristically lined by properly oriented low columnar epithelium, which is sometimes ciliated, resembling tubal epithelium. Microscopic papillae may be found. In borderline atypical proliferating serous tumor, usually have stratified of benign serous type of epithelium. There is detachment of cell clusters from their site of origin and moderate features of malignancy, but there is absence of stromal invasion. In serous adenocarcinoma have multi-layered malignant cells which show loss of polarity, presence of solid sheet of anaplastic epithelial cell, and definitive evidence of stromal invasion. Papillae formation are more frequent in malignant variety and may be associated with samoma bodies. Now, second type is the germ cell tumors. In germ cell tumors, ovarian germ cell tumor arising from germ cell, they produce the female gamete, account for 20% of all ovarian neoplasm. Nearly 95% of them are benign and occurs chiefly in young females. Vast majority of them being benign cystic teratomas, most germ cell tumors of the ovaries have their counterpart in the testes, but their frequency differ from one side to other. For instance, benign cystic teratoma or dermoid cyst so common in ovaries is extremely rare in the testes. Third is the teratomas. Teratomas are tumors composed of different type of tissue derived from the three germ cell layer, ectoderm, mesoderm, and endoderm, in varying combination. Cytogenetic studies have revealed that these tumors arise from single germ cell after its first meiotic division. Teratoma divided into three parts. Mature teratoma. First is the mature or benign teratoma. Vast majority of ovarian teratomas are benign, and cystic and have the predominant ectodermal element, often termed clinically as dermoid cyst. Infrequently, mature teratomas may be solid and benign and has to be distinguished from immature or malignant teratomas. Benign cystic teratomas are more frequent in young women during their active reproductive life. General examination show benign cystic teratoma or dermoid cyst is characteristically a unilocular cyst 10 to 15 centimeter in diameter, usually lined by the skin and hence its name. On sectioning, the cyst is filled with paste-like sebaceous secretion and desquamated keratin admixed with masses of hair. Generally, in one area of the cyst wall, a solid prominence is seen where tissue elements such as tooth, bone, cartilage, various other odd tissues are present. In microscopic examination, the most prominent feature is the lining of the cyst wall by stratified squamous epithelium and its adnexal structures such as sebaceous gland, sweat gland, hair follicle. Though ectodermal derivatives are most prominent features, tissue of mesodermal and endodermal origin and are also commonly present. Third is the second type is the immature or malignant teratomas. The immature or malignant teratomas of the ovary are rare and account for approximately 0.2% of all ovarian tumors. They are predominantly solid tumor. They are more common in pre-pubertal adolescents, young women under 20 years of age. General examination, unilateral solid mass on cut section show characteristic variant appearance revealing areas of hemorrhage, necrosis, tiny cyst, heterogeneous admixture of various tissue elements. And microscopic examination show mature tissue while most of it is composed of immature tissue having an embryonic appearance. Immature tissue element may differentiate towards cartilage, bone, glandular structure, neural tissue and are distributed in spindle-shaped myxoid or undifferentiated sarcoma cell. An important factor in grading and determining the prognosis of immature teratoma is the relative amount of immature neural tissue. Third type of the teratoma is a monodermal specialized teratoma. These are some specialized tumor. Two important examples are there. One is the stroma ovari, which is a teratoma composed exclusively of thyroid tissue. Recognizable grossly as well as microscopically, the tumor has the presence of follicular adenoma of the thyroid. Carcinoid tumor, this is an ovarian teratoma rising from argentavic cells of intestinal epithelium in the teratoma. Struma carcinoid is a rare combination of both. Third type of tumors are the sex cord stromal tumors. Granulosa theca cell tumors. These are comprises of 5% of all ovarian tumors. Granulosa cell tumor. These are the pure granulosa cell tumor in all ages. They invade locally or occasionally more aggressive and malignant behavior. Recurrence after surgical removal are common. Most granulosa cell tumors secrete estrogen. On general appearance, they are small, solid, partly cystic, and unilateral tumor. In microscopic examination, they variety of pattern including the micro and macro follicular tubular bands and diffuse shades. Some are the miscellaneous tumors are also there. They are the lipid cell tumor and gonadoblastoma. They are in lipid cell tumors. There is a small group of ovarian tumors that appear as soft yellow and yellow-brine nodule, which on histologic examination are composed of large lipid-laden cells. These tumors are Hilus cell tumor, adrenal rest tumor, and luteomas. Gonadoblastoma are the rare tumor occurring exclusively in this genetic gonads. This is phenotypic females and hermaphrodites. Dysfunction include viralism, amenorrhea, abnormal external genitalia. Last one is the metastatic tumors. These are 10% of the tumor comprises of this, and they metastasis occur by lymphatic and hematogenous route by direct extension and from the uterus, fallopian tube and sigmoid colon. It occurs frequently. Bilaterality of the tumor is the most helpful clue of diagnosis of metastatic tumor. Most common primary sites from the metastasis to the ovary are encountered are carcinoma of the breast, genital tract, GIT, and hematopoietic malignancies. Truckenberg tumor, which is very important tumor. This is a distinctive bilateral tumor metastatic to the ovary by transcoelomic spread. The tumor is generally secondary to the gastric carcinoma, but other primary sites where signet ring carcinoma occurs, like colon, appendix, and breast, may also produce Kuchenberg tumor in the ovary. On general appearance of Kuchenberg tumor, moderately large, rounded, kidney-shaped, multinodular mass in both the ovary. Cut section show gray-white to yellow, film flashy tumor, and may varies hemorrhage and necrosis. In microscopic examination, there is mucin-filled signet ring cells, and these are in cluster. It is accompanied by the cellular proliferation of ovarian stroma in storiform pattern. This is my reference. I hope you enjoyed this session. This is very important topic. Please read it carefully, listen carefully, understand the topic, and if you have any query, mention it in comment box. Thank you so much. Bye bye. Take care.